Good morning, everybody. It is July 24th, 2025. It's about 11:08 a.m. on the East Coast. And this is Tales from the Heart, Thursday edition, with Dr. Alex Feria from University of Pennsylvania joining us today. Good morning, Alex.
Good morning.
And I know we've talked a little bit about some format changes that are coming to Tales from the Heart. So while I wait for everybody to populate here, I'll just give some messages. Number one, Kristen, who had her transplant on Sunday, is still in ICU recovering, but moving ahead as we would hope. And hopefully she'll be awake soon and we'll get on to that healing part of transplant. So thank you to all of those who have sent your best wishes to her and her family. I was also able to be at NYU this week and visit our other client who is awaiting a transplant and had a dry run last week. So shout out to Melinda, who is currently awaiting her heart. And there is an entire network of pre-transplant, post-transplant patients within the HCM community. While we're only 5% of the population, they're a tight part of our community. So if you have been told transplant might be in your future, I encourage you to join our transplant pathway discussion groups. There's 2 of them every month, and you'll find some friends and you'll find some knowledge there. So that's my announcement on our transplant folks and how they're doing. This is my last day working before some travel. I'm heading out to Seattle to do the community meeting this Saturday at Bells Harbor in Seattle. So I hope you all join us there. If you haven't signed up already, it's not too late. Please join us. We have a great curriculum with our friends from Virginia Mason and the University of Washington. So we have 2 institutions, and our friend Sammy, all the way from Alaska, is coming down to Seattle to talk as well. So we have like a mini conclave going on out there in Seattle. So I encourage you all to come join us. It will not be virtual, it is in person only. So please do come join us. And your entry fees all go towards the Lori funds, and it basically makes sure that you show up. So it's like $20 a head. If you can't afford it and you really need to come, give us a call. We can get you a scholarship, but everything's going back to the community on this one. And thanks to our sponsors who made it possible. So that's the HCMA updates for the day. For those of you who missed the last couple of podcasts, we're changing format a little bit. I give you a little bit of update, and then I ask Alex the question of the day, which is, what do you think is cool and upcoming in HCM that you want people to know about? And I like what you like. So tell us about this scale.
Yeah. So when you asked me what I thought was interesting, recently there was a paper that was published, and that we at Penn were involved. A couple of other centers in the United States, Portugal, UK, multiple centers in different countries gave de-identified MRIs, and they used an AI algorithm and some patient information to try and get at the question: is this 15 millimeter wall thickness criteria how we should be treating this disease? So for those of you that don't know, like the way that we diagnose HCM is a very binary, like kind of either you meet this criteria or you don't. And we're looking at the thickness of the left side of the heart, which a normal thickness of the left ventricle is 10 millimeters thick. And the definition of HCM is greater than 15 millimeters thick in the absence of high blood pressure or another reason why your heart can be thick. But that data for 15 millimeters comes from like 50 years ago, and the imaging quality wasn't even very good then. And so like, it seems like we should be probably a little bit more scientific about it. And, when we do ultrasounds of the heart, we use patient size, body surface area, and things like that for a lot of other things, like size of the left atrium, the top chamber of the heart. And so it's interesting that for something as important as wall thickness, which purely dictates a diagnosis here, we're still stuck with 15 millimeters. And the population that I've always felt strongly about is my women, especially like petite women, because, and I tell my patients this, and I can tell them something different now because I have data, but I used to tell them that my suspicion is that we are very commonly underdiagnosing women. Because if you think about it, some women, can be born, let's say, instead of 10 millimeter septum or wall thickness, it can be their normal is 5, right?
Mm-hmm.
And so to get that relative change all the way up to 15 millimeters and meet a criteria for this condition is a big change for them, as opposed to maybe a male whose normal walls are 10 millimeters and they only have to go up 5. I mean, that other woman patient would have to triple in thickness to meet criteria for this condition. And so I personally have multiple women who have HCM, in my opinion, and they have obstruction of blood flow and they have symptoms and they have scary things happen to them in their lives, who were told you don't have HCM because your heart's not thick enough. And so this study was looking at a bunch of normal hearts, patients with hypertension and other things, and then patients with HCM, and then using MRI and then age, gender, and body surface area, so body size, to try and reclassify people that would or would not meet criteria for HCM when you put in all that other data. And what they found is that, like I suspected, we are underdiagnosing a lot of women and maybe overdiagnosing some other people.
It's kind of silly to think
Yeah.
that a 6'6", 300-pound man and a 5'1", 130-pound woman would be expected to have the same wall measurements of their heart.
Yeah.
But this is how we've lived forever. Like,
Yeah.
normal is this normal, but we're not taking other variables into consideration.
Yeah. The paper, the title of it, Ross, I don't know if you can put it in there because some people might want to read it, is Demographic-Based Personalized Left Ventricular Hypertrophy Thresholds for HCM. It was in JACC, one of our biggest cardiology journals. My name's not on it, unfortunately, but I was very much involved in getting it done. But you'll see my mentor and colleague, Dr. Owens, and a lot of HCM folks from across the country and internationally on it. But I thought it was a good paper. I think it's the beginning of us rethinking about how we diagnose this condition. And, I think it also kind of adds a little bit of light on some of these things that have been preached about. Like, there's data, for instance, that women present later than men, and that women present more sick than men, that women are less commonly diagnosed, or not less commonly diagnosed. The data says less women have HCM than men. That genetically, biologically makes absolutely no sense, right? Because the genes are not sex-related genes. They don't discriminate whether you're a man or a woman. And so I think this data that essentially shows that we're underdiagnosing by using this wall thickness measurement, and that a lot of times it preferentially affects women negatively, is probably what's happening. It's not that women are just presenting later or women are sicker when they present. It's that we're not diagnosing them early enough.
So I'll give some insight. It was in Philadelphia at AHA a couple of years ago. And James Moon, who is the researcher from the United Kingdom who's been doing this work, he's like, every time I see him, I'm like, James, what's new? And he shows me some other cool thing he's working on. So he grabbed me and his study group and he's like, show Lisa the calculator. I'm like, okay. So I got to walk through the calculator in its first iteration. It's been updated a little. I've dropped the link here so you can all go look at it. But it asks very basic questions. And I'm really happy that they've updated this to US measurements because it was all in metric before. And most patients don't do the conversion very well. So you put your age, your gender, your height, your weight, and it gives you a predicted, now this is only a research tool, big note on there, this is research only. We aren't quite to full proof yet, but it's looking pretty good. It tells me the upper limit of normal for me. Pretend I still have HCM. My upper limit of normal should be 12. So anything in excess of maximum wall of 12 would be considered abnormal based on my body size, my height, my gender, my age. So the predicted wall measurement for my age, my height, and my weight for my predicted wall measurement is 9 millimeters. My upper limit of normal is 12, but diagnostic for HCM is until 15. But what if I were 14? I think it's still a diagnosis. I'm gene positive, so we know anything over 12 and gene positive would be considered diagnostic. But what if you're not gene positive? What do we do with that? So we're learning more, but I think we're going to get better at diagnosing women if we look at them as individuals rather than bulking them with all the other humans, which happen to be male and a lot larger than us. So,
and not only from a diagnosis standpoint, but if you think about it, the next step from a risk stratification standpoint, like, is a woman going to need to have 3 centimeter septum to be considered higher risk? I have families that have clear-cut genetic HCM, and they've had sudden deaths and not had the traditional risk factors. And one of my patients clearly has the gene, it's pathogenic, disease-causing gene, and was told she didn't have it. But if you look at her MRI closely, septum is 13 or 12. 12 is what the septum measures at. The other wall is like 4. So it's a 3-to-1 difference. It's asymmetric. It's just not meeting the criteria. So I think that it might not be super sexy like some of the other stuff that's out there, but to me, this is like
I think it's super sexy. I've been using it in our navigation calls for about 2 years now. I think it's super cool because we're not getting enough women diagnosed.
Yeah.
They're looked at that it's not that bad. And I will tell you, hands to God on this one. 3 weeks after I saw this tool for the first time, I had a run of women over the age of 55, under the age of 65. They were all from Wisconsin, Michigan, and Minnesota. And like all these calls that I had in like a very short period of time were all these women, and they were all tiny. They were all like under 5'3", and they were all under 140 pounds. And I just think it was the universe's way of telling me, like, pay attention to that tool that James Moon just showed you, because every one of them, they were borderline diagnosis. But when we dug into the family tree and we pulled the rest of the diagnostics together and we looked at genetics on some, we didn't get it on everybody. But this is real HCM with wall measurements of 13 and 14 and 15 and pretty severe presentation in these women. Diastolic dysfunction, mitral valve abnormalities, all the other things we see in HCM. But because their wall measurements were barely 15, they were being told, this isn't your answer. Yeah. We got them to specialists, and every one of them was a confirmed diagnosis when we got through the entire process. But this is what the problem is. We don't know what these numbers really mean, and we have to do better.
Yeah, and if you miss the very initial part, the diagnosis, then that means they never get any kind of provocative testing. So they never get Valsalva on their echoes. They never get put on a treadmill. And they keep coming to you and saying, I have these symptoms. And then you do a resting echo and you don't do anything. You just look at her and you're like, oh, everything looks fine. But then you just have them bear down, or you put them on the treadmill and they have severe obstruction. That's happened to me multiple times. And so, you talk to these women too, and for years they felt bad.
They're gaslit. They're told they're crazy. They're told they need to exercise more. If they ate less, they'd be better. And in reality, they have an underlying heart muscle disorder that has very serious consequences that's not getting met.
Yeah.
So
I think in the next 5 years, we will look at the diagnosis differently, like how you diagnose people, and it will be more personalized.
And I will say that thank you to everybody who contributed to the science that led to our current understanding and the newer understanding. We can only work with the tools that we have, and imaging technology in the 80s and 90s was, you could kind of see walls. Yeah. We're better now at imaging. We're better at MRI. We're better at understanding genetics. And I think we're better at understanding gender differences and disease manifestation, and it's critically important that we continue down this path. Okay, so we agree that James Moon's tool and all of the research around it is super cool. We put the link out there for the public. It is a research-only tool. You can't do any, decision making off of this other than adding it to the equation for conversation with your care team. That's what I would say at this point. All right, pivoting to the next section of Tales from the Heart. So today's topic, this month's topic, is about Center of Excellence care. So when I knew I was going to talk to Alex this month, I said, okay, I always introduce you as doctor patient. And first you were the patient and a consumer of the system. So can you take the listeners through the family history and young Alex and the fact that I didn't put two and two together for a while, like who Alex was. And I'm like, oh my God, you were the 17-year-old who went for a myectomy. Like, whoa, I remember that kid. And now I know this adult. So tell us about what happened.
So my brother and I grew up in a small town in Georgia, Milledgeville, and we were in military school. And my brother had a syncopal event when he was 15, and we were 11 months apart, so I was 14 at the time. And fortunately, in retrospect, it sounded a whole lot like he had a cardiac arrest. And fortunately, I don't think he was resuscitated. I think he just converted to a normal rhythm and survived. And there were no cardiologists in Milledgeville. Someone came once a month from Macon, but that was it. And so we ended up going to Macon and got very lucky that we met a cardiologist named Michelle Grenier, who had trained under a guy named Jeff Tobin, who happens to be a world expert in pediatric treatment of HCM. And so she immediately diagnosed the condition, even though, to be fair, I never saw his echo, but the way they were described, you would have to be blind to not diagnose us on echo. And so then it was like, okay, well, we need to go to a center that sees this. My parents are both physicians, and so we had the fortune that they were like, okay, well, we need to see someone that knows this. And then she said the same thing. She said, go see Jeff Tobin. So we flew to Texas to meet him and were formally diagnosed. And then...
Wait, let's give a shout out to Jeff Tobin, who retired on June 30th.
Oh, really?
Yes. So shout out to the incomparable Jeffrey Tobin, and thank you for all of the years of service to this community. We are all smarter because of you. So, Jeff Tobin, next.
So then we established care in Atlanta that had an HCM center at Eggleston in the Children's Hospital, and had my brother had more issues than me, so he had at least at that phase, and I also was in denial. But so he had an electrophysiologist there and an ICD put in when we were kids, and then we transitioned care to Atlanta, to Emory, when we became adults, and we're seen there by Dr. Williams and his team. I finally got my ICD after I went to the University of Georgia for college, and I was one day bored studying and looked in a book and reading just about HCM in the science library, and came across this guy named Barry Marin's name over and over and over and over and over again. So I was like, you know what, I'm just going to...
That happens in this space.
Yeah. So I said, I'm just going to email him. I was 19 and or 20. And so he responded and said, come up and see me. And so I went to Minneapolis, which is where he was at the time, and got an MRI for the first time. Wow. And, it kind of shows some of the differences in thought process in different centers. I had been taken care of at one center, but then I went to see him and he was like, you need an MRI, which then led to being told I needed an ICD. That was like a week before I took the MCATs. So that was like a good wrench. So I got that. Then was my third or fourth Center of Excellence that I was a part of. I was at age 20. Then I went to Vanderbilt for medical school, and then was part of the Vanderbilt program, which wasn't really, I think, a Center of Excellence.
Not at that time.
But Yeah, they were not a center of excellence, but I got lucky, and also I sought it out that who became my mentor, a guy named Jason Becker,
Ah, yes.
also took care of me clinically, and he's now part of the HCM Center at the University of Pittsburgh.
Yep.
He told me, you need a myectomy. You should go to Mayo Clinic. And so then I went to the Mayo Clinic and had a myectomy and met Steve Amon.
We're at
That's
5
right.
programs. You've hit
Yeah.
a Marin and Amen. Okay, keep going.
That's 21 at
At
this
21. Got it.
Had surgery with Joe Deraney, and then was out for a couple weeks, went back to medical school, finished medical school, did a year of research in HCM while I was there. And then I went to Brigham and Women's Hospital for residency.
Okay, 6 centers.
Was taken care of by Neil Lakdawala, who's also one of my mentors and excellent HCM physician.
You got Neil hair. Like you and Neil have the same hair.
Yeah, I've been approached at HCM conferences and people talk to me like I'm important, and then not very long into the conversation, I realize they think I'm Neil Lakdawala.
You kind of look alike. I'm not
I
gonna
look
lie.
like Neil Lakdawala.
You kind of look alike. Okay.
He's lovely and a great doctor.
Yeah,
he is
great
who I send when people in Boston, I send a lot of patients to him. And then when I was looking for training for HCM and cardiology, I looked at Penn. Well, I looked all over the country, but I looked at Penn, and I met a phenomenal doctor named Anjali Owens, who established the center here. And then a year into my training here, the head of the program that was started at Michigan, Charlene Day, joined us. So then I had 2 of the biggest names in the country here.
Like 7.5 centers because she left and came there, but
Jason, yeah.
Okay.
And
Keep dropping names, Alex. Keep dropping names.
And then I stayed here. I trained here. I did, Matt Martinez started a program the year after I did this. So I still think I'm the first person to have formalized training in genetic cardiomyopathies, specifically HCM, as a trainee.
Okay, let's pause for a second. So patient Alex. So patient Alex has a very interesting journey because it's familial. You and your brother are both diagnosed. You're being a patient, you're being a brother to a patient, different dynamic. You're trying to figure out what you need to do next, and it keeps getting layered on. Now we need an MRI. Now you need a device. Now you need a myectomy. Now you need meds. Now you need this. Now you need that. How is that to process, not as a med student, not as a future physician, but as a 21-year-old student, a 20-year-old kid? Like, what was it like for you?
It was a blessing that I didn't know a lot, to be honest, because the more you know, I think sometimes it's harder to make medical decisions.
I'll give you that. Yeah.
It can be jarring and confusing as a patient to see multiple specialists that have slightly different opinions or styles or the way they interact with you, or even like treatment approach. And that happens now with me. I have patients that have seen me and 3, 4, 5 other HCM specialists, and so that still happens. And so that's hard. That is hard. And almost every single patient I see has seen at least one cardiologist. Now I'm saying not HCM specialists, but most of them have seen that. And so I think that's probably one of the hardest parts is it's just everyone, there's an art to medicine, and you get different opinions from different people. And it doesn't mean they're right or wrong. They're just different ways of approaching it. And that's HCM specialists, non-specialists. So that part is hard. And then I was fortunate in that my path led me to a lot of places where I could get excellent care. But a lot of that was I sought it out. When it came time for my surgery, I wanted to go to the place that did the most. My brother wanted to go to the place where he was closest to home. He had his myectomy at Emory. I had my myectomy at Mayo. And that's personal preference. Again, no right, no wrong. He had no obstruction after his myectomy. So did I. And so, I think that's a personal approach. And again, also like the benefit and, the fortune of being able to travel. Not everyone can travel to Mayo. I was able to.
And we have made it a little easier for some. If you can't get to
Totally.
a center of excellence, the Lori Fund is there for you. And we've built more centers.
Mhm.
Got a
That's
great
different.
note.
That's different. Like,
Yeah.
we have excellent surgeons in this region. Like, my opinion, there's very few scenarios where you would have to travel if you live in the Philadelphia area to Mayo or Cleveland if you need surgery.
I'd agree today. There's some anatomies that I would still go, "Ugh."
Some. That's why I said there's not.
Yeah.
It's not always, but there are some instances where I still tell patients, yeah, I'd probably, if it were me, because I talk to all my patients as if I was going through it, and I tell them what I went through. And I tell them, I feel comfortable with you having surgery here versus I feel I would want you to have it here.
So let's take a little bit of a pivot here. So you come from a family, you know what the disease is, you've lived it, you felt it. So can we just talk about symptoms? Did you notice symptoms or did you think things were normal as a patient?
I would say I honestly feel like I was asymptomatic until my freshman year of college. Part of that was, I think, because I was so restricted when I was in high school. Like, I was in military school, but like it was restriction almost in a cruel way. Like, that I was forced to like walk laps around the soccer field while everyone was even just doing minor recreational fun stuff. It felt almost like, and part of it was because military folks didn't really believe it was a condition and all this. So like I had to walk laps around the soccer field and watch people play. Like, I couldn't participate at all. And so I think that when I went to college, I was like, no one's here telling me what to do at all. So I immediately tried to start playing pickup soccer again. And remember the first time playing indoor soccer that I had to just tag out and run out of the gym and squat and sit there and breathe because I couldn't breathe. And so I remember that day because it's the first time it's ever happened to me. I was 18. And so that was when I started having symptoms. And then I, went through college, and William, my brother, always was more symptomatic than me. So I think that also made me feel like it wasn't as big of a deal because, like, look what he's going through. And so, yeah.
So I would like to just bring up the emotional component of HCM as well as a patient and a family. And we share something that we don't want to share, and that's we each have lost a sibling to HCM. And while you're practicing as a physician in HCM, there's always the piece of you that lost his brother to HCM. How you want to talk about that at all? Talk about your brother a little bit?
Yeah.
Oh, honey, I'm sorry. No matter how long it is since we lose these people in our lives, when it comes up and we really start to think, I call it memories fall down my face.
Yeah. Last week was 3 years, last Thursday.
Oh, anniversary time. I'm sorry. I forgot that it was anniversary time for you. I should have remembered.
It was 3 weeks after I became an attending. I finished my training and I started practicing. And it came out of nowhere. It's hard. It's hard. I left work for a month and a half.
I know you were just starting your first HCM clinic, and we had to, Anjali jumped in and took appointments for you those first couple of weeks. I remember that. And then it was like, okay, how do we support you coming back?
It was hard. And I don't, I talk to my patients. For some reason, I haven't cried about this in like 2 years.
It's an
So,
anniversary. Thank you for being real and vulnerable to do that. That's hard.
but I talk to my patients about it all the time. I talk about William all the time. And it's hard. Patients, if I had every resource that I wanted, I would have therapy as
I'm
part of
building it, honey. I'm building it. I'm gonna get it there.
And it's something that we don't talk about enough. And it doesn't have to be loss. It can just be watching someone
Suffer.
Yeah. That's lost in itself.
It's
And
not
having children with it. Like there's so many different dynamics. The sibling grief, the parent grief, the grandparent grief when you sit there. We sometimes diagnose people later in life and then they realize that like so many of their family members have been suffering and then they find out that the gene came from them, and that's just a very complex grief
genetic guilt
to process. And so it's tough. That part is tough.
So that is the underpinning of Dr. Feria. So we have that patient experience, that personal experience, and then you made a choice similar to a choice that I made to take the thing that has caused you the most harm, and you're like, I'm in. Come on, HCM, I'm in for the fight.
Yep.
I can beat you. And now you're in one of the top genetic cardiomyopathy programs in the country. You're seeing patients, you're offering them cutting edge treatment, you're helping them navigate this system and understand the science. What is it like, doctor, to be the patient and the doctor together but apart?
Yep. It's great. I wouldn't do anything else. I'm happy every single day I come into work. And I think people appreciate it, honestly. I talking about it and talking to someone that knows how they feel. I mean, so many people say, I've never been asked that question, about symptoms or about all kinds of things. I think part of it is just because unless you felt it, it's very hard to articulate like how it feels. To get short of breath after eating a big meal, or why do I always feel like crap on Thanksgiving? It's like, it's not the tryptophan.
It's not the tryptophan.
It's you. And
Fluid
so,
chips.
it's a privilege.
So having the unique perspective of the past 18, 20 years of being the patient, being the student, meeting all the players and seeing how different centers operate, you're now in a center that has all of the logistical issues around a center and the care model that it is developed into. Why is Center of Excellence care critical for HCM patients?
I think that their general cardiologists in the community are always going to be crucial for identification of disease and for co-management.
Yeah.
And I have tremendous respect for them. And I co-manage, unless if my patients are here and they just want to only see me. I have many patients that come from New Jersey, from Delaware, from New York, northeastern Pennsylvania, hours of travel. And I co-manage my patients with them all the time. It's because I want them to have someone local.
Absolutely.
But I think that there is just like anything else, if you do it all day, every day, like I'm fortunate in that all I see is genetic heart problems. So 75% of what I see is HCM. I meet 6 to 7 new HCM patients a week. And so when you see something over and over and over again, it streamlines your care in a way that I think sometimes people kind of languish for years from a treatment standpoint, from a risk stratification standpoint, from a family screening standpoint. Um, and so I think that having all of those tools, like a lot of times I would see my patients and I'd see them on the same day that they see the interventional cardiologist and the surgeon to see if what treatment they need. And these are people that drive 4 hours away, so like you don't want them to have to come back and forth for different things. So having all of those tools with you, I think, is a really big asset for the patient. And I think that sometimes symptoms may be undetected or underappreciated if you don't see someone that sees it a lot, and people are told they're fine when they're not. And so I think it makes a big difference.
So tying into our opening conversation about better diagnostic criteria, how many patients do you think, well, you might not be able to put a number on this one, but does it happen often that people are gaslit that there's nothing wrong with them when there's something structurally wrong with them? And does that shut people down from talking about their symptoms because they don't want to be perceived as, quote, crazy?
Yeah. I mean, not only do I think people are told that their symptoms, particularly women, are misattributed to, weight, menopause, whatever you want to name it, but I also think that part of what we used to do, which is restrict people so much, like then makes our patients that have a known diagnosis then struggle from other things like obesity and whatnot, which then makes them develop symptoms, which then makes it even harder for people to listen to them. Like when they have true symptoms, but they weigh a lot more than they should because we told them they can't do anything with their lives. And so some of it is self-imposed. When I say self-imposed, I mean our establishment. But yeah, I mean, I think that I see that very frequently. I also see a lot of we're not sure what this is, but this is normal for you, especially with my apical patients. All of my apical HCM patients, have had an abnormal EKG that looks not all of them, but a lot of them have had a very abnormal EKG that looks like apical HCM for a long time, and get stress tests and caths and all the stuff. And because it all comes back unremarkable, are told, this is EKG is not normal, but this is normal for you. And then unfortunately, they'll go for a long time without seeing anybody and then have a stroke or something devastating because they went to AFib and didn't feel it or whatever, or they've had symptoms. And then it's a tough conversation to have when, like, I had a patient the other day that brought me an EKG from 1994.
Oh, God.
And I was like, well, yeah, looks like apical HCM.
I have a thing that's been happening the past like 8-10 months. People going back and being able to access their imaging much easier than they used to be because of electronic medical records and portals and whatever. And they're going back and they're getting 8 and 10-year-old echocardiograms because they were done because of symptoms and they were told everything is fine.
Mm-hmm.
When you look at it, it walks like a duck, it quacks like a duck, it's got feathers like a duck, and they call it a dog. And it's there. It was there 10 years ago. And we lose this time because of a lack of appreciation of the meaning of hypertrophy in these hearts. And apical, particularly, imaging the apex is not simple, and you need a good protocol. And community docs don't always get that apex measurement really well. And they just underestimate it and they ignore it.
Well, in contrast, giving contrast with echoes, I think, is one of the biggest things that's changed the diagnosis. Because a lot of people say MRI, but you don't get an MRI unless you have a reason to. But you get echoes for a lot of things. And giving contrast with echoes has lit up the inside of the heart, and all of a sudden it's like, okay, there's something abnormal there.
Now we can see it. We can see it.
And so, yeah, I would say a lot of my patients have had frustrating interactions previously. And that's multifactorial. Again, I don't say this in any way to disparage community physicians. I think they have all their own constraints. Being told they need to see X number of patients in X number of time and having to go through quickly and all that stuff. I have the fortune that I my new patient visits are an hour and a half. My returns are half an hour.
So going back into why centers matter, we set up an infrastructure. Now, every center doesn't have an hour and a half new patient.
No.
A lot of them will have an hour. Some of them will have an hour quote plus. So there's nothing right behind it. So you have some time. But a community cardiologist, you ain't getting an hour. And if you got an hour, I don't know what they would talk to you about because I don't see a lot of HCM. But you need that community doc. You need your trusted specialty team. You need an emergency action plan for when which one gets invoked, and everybody needs to be on the page. And that is what's leading to better outcomes. Here's a data point that's not really published. I got to get it published. Maybe we should work on this. So back in the day, and I can go back to 2008 on this one, I became addicted to this thing called the Wonder database. It's managed by the CDC. It's not working the way it used to work, and I hope it'll go back to its old functioning soon, but it's death certificate data. Death certificates aren't the best way to determine cause of death because it's not always correct, but it's a good starting point. And back when I started looking at data, which was from the late 90s up until about 2007, the average age of death for somebody with hypertrophic cardiomyopathy, if you looked at all the deaths that were happening, most people were dying between 45 and 54, midlife dying. And there were about 1,600 deaths per year attributed to HCM over this time period. And then I went back and I revisited. And I revisited like 10 years later. And the numbers started to change a little. There was a peak in 2016, 17 in the teenage to early 20s, but it crossed over with the fentanyl epidemic. So it could have been a combination of issues there where there was a little pop there, but that's now balanced off. But the latest data that I got, which was in December of 24, the average age of death has moved out 2 decades, and we're living into our 70s, much more than we were before. And yes, there are deaths along the lifespan, but a lot of us are making it to the fourth quarter now, when previously we were checking out at the end of the second or the beginning of the third, right? So we're living longer, we're doing better, we're able to say that we've improved because we changed the care model, we changed the treatments, we got ICDs in people who needed them, we got transplants in people who needed them. We're better than we were. And that's because we're working collaboratively to find solutions, center to center, industry. We're all working together to try to get these patients diagnosed, identified, and treated properly. And that's been pretty cool to watch it evolve over the past 30 years. So you were a consumer and now you're part of the game and you're treating so many patients. And that's got to be a unique perspective that pretty much only Alex has. Like there aren't many people.
I don't think there are I don't know of another HCM doctor that's told me they have HCM.
There's 2 others, but they didn't have your childhood and you have a very real, repeatable, common, unfortunately in our community, family experience with HCM. The early diagnosis, the school stigma, my brother's different than me, he's worse, I'm better, he's gone, I'm here, grief, genetics, next generation. So you're living in the middle of it right now. I have another physician who has been public about his diagnosis, but he was diagnosed after the site visit when he's like, they're talking about things that sound familiar and I keep passing out. And he did his own echo and he's on Camzyos now. So there are other doctors out there who are living with HCM. But I think my lived experience and your lived experience of what HCM was at home are more common to the community than the other 2 docs that I have right now. So you have a very, very unique perspective and one that I think is critically important to us developing. Okay, let's talk about the thing. Better patient-reported outcomes, better patient-focused initiatives to really meet our needs.
Yeah.
So, and this is something that we've been working on together. We've got some questions and comments coming in. I do want to go back to Mike Terry. Mike and I have known each other for many, 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 many years on phones and computers. I got to meet him in person in April in Florida, so that was really nice. And he's again another one of these families with 4 sudden deaths, transplant, complications. Mike, I see you, I hear you, I recognize you, and I thank you for being part of the community, even when it's hard. So just want to acknowledge that one. Got a question from Carl. Are there HCM centers that do extremely well with AFib and other rhythm issues? Well, for those of you who are listening and you didn't see the hand rise from Dr. Alex pointing at himself, so there are a lot of programs that have really aggressive atrial fibrillation programs, and it's critical that you go to a program that understands the HCMA fib versus all-cause AFib. And there are a lot of centers that are using some new techniques. You want to talk about some of the new techniques to manage AFib?
Yeah, I mean, so I'm obviously biased, but some of the giants in electrophysiology, so the electrical doctors that treat AFib are from Penn. And we have an army of electrophysiologists. But what I would say is there's different techniques for ablation, how they go in and they use catheters to try and get rid of AFib. There are also ways that they can approach the atria from outside and inside to try and treat the rhythms. And then there's antiarrhythmic drugs that we use that don't have bad long-term effects, that also don't cause low heart rates, which some of the other ones do. And so, what I would say is there are lots of the HCM centers have excellent electrophysiologists. So I would probably look towards an HCM Center of Excellence and see who their EP person is. If you live near Philadelphia, I would say, my electrophysiologist is the head of electrophysiology here, but I think that they are phenomenal here. But I will say it is important, because I have plenty of patients that I've seen that have gotten ablations that failed and then they go back in. And so you don't want to sit in AFib for a long time and just deal with the symptoms, because the longer you're in AFib, the harder it is to get you out of AFib. And so I would try and act on it soon.
So I will comment again on going to a center of excellence who understands HCM and AFib. 4 or 5 years ago, we would have said, if you've had 3 ablations, radiofrequency ablations, it's probably not worth it to do a 4th, because it's probably not going to change anything. But there are new techniques today that are a bit more aggressive in how they're going after this AFib. So you want to talk about what techniques they're using, what systems they're using. Is it worth another try? I think it's always worth 1 or 2 tries to try to get you out of AFib. But that 3 and 4 time, you definitely want to work with a specialist, and you want to make sure you're not just adding more scar to add scar, because when you go in and do ablations, you're adding scar tissue. So you want to make sure that they are focused on getting you into sinus rhythm as quickly as possible. Okay, so 2 more questions. Michelle, Boston cardiologist, you've got a lot of cardiologists in Boston that treat HCM well. Obviously, we have our program at Leahy with Marin, Rowan, and Marin. You've got Brigham and Women's with Neil Lakwala and Carolyn Ho. Libin Wang is over at Tufts and kind of managing the legacy HCM program that was Tufts, and we do still have a great relationship with them. So you've got a lot of options in the Boston area. You don't even have to leave town per se, or if you can go out to the suburbs, if you want to go out to Leahy and not be in the city proper. So you've got a lot of great options there. Look at the HCMA directory listing and we can guide you there. And then we have Sherry. What are you saying here, hon? Someone who is actively running and cycling, would you recommend seeing an HCM center that specializes in sports cardiology? Sherry, thank you for asking that question. And I'm going to address, and then I'm going to ask Alex to address. I will make this the final question, because I've got a car picking me up in 15 minutes to get to an airplane. So I got to go home. So my personal opinion is I do not believe you need a sports cardiologist to exercise with HCM. I think you need an HCM specialist who understands the anatomy and physiology of both a normal heart, an HCM heart, and what we're going to be doing with that HCM heart during exercise. For competitive athletics, for, I would say, collegiate level and above, maybe even high school level, varsity and above, I do think that there's some benefit to getting a sports cardiologist to give a consult and make sure everybody's on the same page. But sports cardiology is not HCM, and HCM is not sports cardiology, but they can work together. But just because you're active doesn't mean you need a sports cardiologist. Alex, what do you think?
I agree. I know of 3 HCM doctors who are also big sports cardiology in that realm. So I would think that if, like Lisa said, if you're doing very high level stuff, or if there is some nuance to your risk that maybe you feel like there is some risk there, like either there's a scar on your MRI or something like that, and they're trying to figure out your risk factors and if there's any reason why you shouldn't be able to exercise. Most HCM experts should be able to handle that. But I would say, so here, Charlene Day is one of my colleagues. She published the papers on exercise in HCM and changed the guidelines. But then there's Matt Martinez, who's a world-renowned sports cardiologist and HCM doctor in New Jersey. There's Dermot Phelan down in North Carolina. You know, there are people, if you have a unique case, and especially if you've been told not to exercise and it doesn't make sense, there are people that you can see in the country that is what they do. And there's more. Those are just the 3 that pop up on my head right now.
Okay. I lied. I'm going to address one more because Christopher has a really good question, and it's across the platform here. Okay. Don't shoot the messenger on this one. You are never going to get an insurance company to approve a 90-day prescription of Camzyos because it's too expensive, and they're kind of hoping that you stop taking it after 30 days because it's a very expensive drug. I can't get a 90-day supply of my transplant medication because it's a specialty pharmacy and they won't give me an exception. So I do not see any payer system going ahead and providing you a 90-day prescription. Given the REMS program, you can't do that for the first 6 months anyway. I hope that some point in the future we do get to a 90-day fill on this, but I don't see it anytime in the next 3 to 5 years. Realistically, if you're gonna choose a battle, I don't think this is a winnable battle right now, and it's strictly based on the price of the drug. And you're asking the insurance company to assume that you're going to stay on this drug for 90 days. We think you're going to stay on the drug for 90 days, but they're hoping you don't. So the strategy is a little bit different. Alex, any comments on that one?
Yeah, no, I agree. I mean, I thought it was a win that we were able to space out the echoes, but every patient's asked that to see if they can get a longer stretch of meds. But unfortunately, I've had more issues, honestly, getting people on drug this year than last year. A lot more battles. You have to have tried beta blocker and calcium channel blocker and all this stuff first. Maybe once some of the data for the MAPLE trial and other things gets a little bit more, comes out, then maybe we can, use that.
We got a couple of weeks to go for that. I will be in Madrid, Spain when the new data comes out, and I'll probably do a quick podcast from there too. But we'll get the data as quickly as we can into everybody's hands, and God willing, things will get a little easier for us. But I don't think that, given the changes that we're seeing in healthcare, that things are going to get easier in the next 24 months. I think things are going to get harder, and I think they're going to get more restrictive, and I think we're going to have more battles. Not that I like anything that I just said.
Yeah.
But I think that's the reality that we're living in. Okay. So guess what just happened? My tablet got put in the backpack, and the backpack is ready for the airplane, and the airplane is ready for Seattle, and I'm ready to go meet some people in Seattle and spread some HCM awareness, show a little camaraderie. And if you haven't signed up for our Seattle event, it's not too late. You can still do it now. Alex.
Yeah.
Thank you for sharing perspectives on the patient and the clinician point of view about centers of excellence.
Happy to.
I truly appreciate your candor and your vulnerability. And I know some parts of this journey really suck.
Yeah.
They really do. But having a team with people like you on it makes it a little bit better for patients. They know that you understand. They know that you understand from the personal and the clinical and the scientific. So thank you for your chosen path in life. Thank you for being part of our wonderful community. And I still remember going back to my files and like, who's this Feria guy? And then finding a file with your mom's name on it and going, oh, I remember this.
Well, thank you too.
I would say happy to do it, but it's more just, this is what we do.
Yep.
This is the battle we've chosen to attack, and we've got this. Okay, I'm off to an airport. Thank you all. Thank you, Ross, for dropping this. I will talk to you all in a week or two. Stay well, stay online, and we'll talk. Take care, everybody. Thanks for joining.